today. Very special opportunity. Staying healthy years after heart transplant, changing focus of care over time. How many here have received a heart transplant? Isn't that amazing? All right, put your hands down. How many are between, this is your first year, you're under 1 year. Great to see you out. All right, how many between 1 and 2 years? Way up there? All right, glad to see you getting exercise going up there. 2 to 5 years. All right, look around you. I mean, this is inspiring. We always do this. Thank you. 5 to 10 years. 1, 2. All right. 3. Put them up again. 1, 2, 3. Okay. And 10 to 15 years. All right. 1, 2, 3. All right. Hi, Maureen. Didn't see you come in. You look so sharp today. With our heart and everything on. Isn't that great? 15 to 20 years. All right. I'm still 15 to 20 years for 2 more days. And then I hit 20. All right. Anybody over 20 years? Way to go, John. Did I miss anybody? There was 2 people with their hands up over 20. Did I miss anybody in the darkness there? All right. Hey, thank you for coming out. You are such an inspiration to all of us. And of course, that's what we see so different these days. Every story is different. The average is what it is, but people like yourself come out and you see, wow, I guess I can do it too. And I hope and pray that you too will be here to raise your hands at over 20 years someday. And that's what it's all about. So I'm so glad you came out. And on behalf of Second Chance Heart Transplant Support Group, for those of you who don't know about it, is a local group consisting of over 800 heart transplant recipients. You thought you were all alone when you got into this, didn't you? You're not alone. They've experimented on a lot of us, and you're surviving because of that. And so here's our president, Dan Smith. Dan Smith is famous not only for his heart transplant, but he's got 2 sets of twin girls. So he lives in a family of 5 women. That's what probably wore out his first heart. And he's doing so great. In the middle there is Jerry Cohen. Jerry Cohen passed away about a year or so ago. And he is amazing. He got his transplant in 2000. And I was going to bring a video, too, of him sharing what life was like. He was still working as a judge in the system here at the age of 80. And I got to tell you, I went to his funeral, and the family was amazing. He adopted so many kids. He had a family of young people that spoke so beautifully of his life. And then you have Steve Herman. Steve is known for being a clown, truly a clown, you know, a serious clown. And he does amazing stuff, helping all sorts of people, especially with the Shriners. And so today we have 2 very special guests. Most of you know both of them. But if you did get a chance to read the flyer that came out, let me review it, okay? Pat received her bachelor's degree in nursing from the Pennsylvania State University, her master's of science degree in nursing from the University of Pennsylvania, and a postmaster's certificate as a nurse practitioner over at Drexel. Working with heart transplant recipients for over 23 years, first at Temple University, then Hahnemann, and finally at Boston University of Pennsylvania. And there's an amazing history of the program that's moved around here over the past 20 years. It's been fairly stable for the past almost decade. But before that, it was amazing. And so she followed around, didn't you, Pat?
I did.
And then you have Maria, who joined us more recently, board-certified adult gerontology, acute care nurse practitioner, certified as critical care registered nurse. She received her bachelor's degree in nursing from the University of Manila, Philippines, her master's degree in acute critical care from the University of Medicine and Dentistry of New Jersey, and a postmaster's certificate in teaching from the University of Pennsylvania. She worked as a critical care nurse at the Hospital of Lady of Lourdes for over 10 years before finding the light and coming over to the hospital in 2009. Since then, she's been working with heart transplant recipients, and I got to tell you, she always says she doesn't know half of you because you're been out there so long, but she says, Pat's been my mentor, so accept me. And you all have, so that's really great. With that, I just want to leave you with one final message before we move into the talk. Dr. Wilhelm, in January of this year, shared the following. A remarkable number of patients survived 20 or more following heart transplant, confirming the procedure as the gold standard for end-stage heart failure, at least for the time being. With continued improvements in immunosuppressive management in the coming years, we expect to see transplant patients living longer, healthier lives. It's still uncertain if mechanical circulatory support devices will be able to compete with heart transplant in the future. And I'm turning off my cell phone, so if you have yours, please turn it off. I was at a forum down in Baltimore on Saturday and listening to their heart surgeon talk about it. And he said, you know, there's no growth in heart transplant anymore. It's limited by the number of people who are donating. And so part of our mission is to get out there, spread the word of the success, the lives you lead post-transplant, so that that number will change. But it's around 3,000 a year. A lot more people need heart support. And so those mechanical devices really have become the growth industry today. And I got to tell you, I seriously, some time ago, thought about it. If I passed my 70 mark, and with diabetes and too much here, but you know, if I ever need a second heart transplant, they probably wouldn't consider me. And so I accepted that. But now that I see the work on the mechanical side, you know what? There are options. You've lived long enough. And just like the initial immune suppressant drugs from 20 years ago, toxic, the kidneys started showing up as problems. I lived long enough that there are new medications that you and I now share. Less toxic, but still toxic. And so as you live longer, the medical advances are such that we stand even a better chance going on. And so I'd like to just leave you with that thought. And here's some people that in 2009 were 20 years out at our second chance dinner dance, which you're all invited to, by the way, in the springtime. We'll talk about that later. And with that, I'm going to stop and pass this over to, who's speaking first? Maria? Are you staying healthy?
Mm-hmm. Lovely audience. So thank you for coming today. So I'll be speaking, giving a little bit of background first, with staying healthy years after heart transplant, changing focus over time. As you are aware, you are here at the best, I should say. Penn Medicine is the largest heart transplant center in the Mid-Atlantic region and one of the top 3 heart transplant programs in the nation. Surgeons at Penn have performed over 1,000 heart transplants since the program began in 1988. More than all of the other centers in the region combined, so Jefferson, all of them. We have the most number of transplantation. As of 2010, we were ranked number 8 in the world. We always do the multidisciplinary approach into a patient-centered team approach, as you would see here. Oops. We have our surgeons, Dr. Hackers here, our cardiologist, Dr. Chessa, Dr. Capola, and of course your lovely nurse practitioners, Patty's there, I'm there, Mika, Mary, and of course we have our pharmacist. Sometimes probably when you call, we always say, if you want to start another medication, hold on for a second, we have drug reaction to be checked, we always refer to our pharmacist. Her name is Tamara, and of course we have our social workers, who's like the glue of the team, and of course fellows that we train and then hopefully stays with us, like Dr. Owens is with us. So I just want you to know that it's a multidisciplinary team and we always talk to each other planning your care. Just to give you a little bit of the statistics, if you want to check out anything about heart transplant or anything about transplantation, you can go to the SRTR. This is like a registry in the whole United States that kind of like rank each center, how they perform, the survival. So at Penn, we persistently above, for the last several years, we're always persistently above the national average until last year. So we're a little bit behind for the first month and also the first year. But as you probably are aware, we always get the sickest of the sickest, like who are like high-risk patients and need transplant risk patients. So that's why we have actually devised risk stratification strategies on how to bump up that number again and be on top of it again. And then of course, 3 years, 5 years, we're always above the national average. So the longevity is always there for transplantation. So, because we work as a team. And I'm sure all of you are asking, why do I have to go to Penn every 6 months? Why can't I just go to my local cardiologist? Ongoing saga that everybody wants to know. That's the one that we're going to be answering today. That's the purpose of this talk. So you're aware, I think Jim already alluded about the kidney disease and stuff like that earlier, and his lipids and his diabetes and his stomach, as his growth rate. You mentioned that already. So those are the facts where we have to see you every 6 months. Every 6 months we check on your lipids, we check on your blood pressures, we check your kidney function, which is the creatinine, and of course, we always check your lipids. And of course, we also refer you to your primary to make sure that the diabetes is well controlled. Because this ISHLT, this group, is an international society of heart and lung transplantation, so Europeans and then of course Americans join forces in putting all this data and comparing outcomes. And it's always been noted that hypertension is a big deal, renal disease is always a big deal, hyperlipidemia is a big deal, and of course diabetes. And the number one of all of these is ocratic allograft vasculopathy, or sometimes we call it transplant arteriopathy, or sometimes referred as transplant atherosclerosis. I'll give you an example of that later on, but the main focus about that is that in 1 year, you'd see that it's only like 7.8% in the first year, and then at 5 years it's 30%, and you would see at 10 years, it doubles, and it goes to like 50%. So this cardiac allograft vasculopathy is a limiting factor of graft survival. So we at Penn concentrate on this. Of course, you always make sure that your blood pressure is always good. We always check your kidney function, but the main focus now is for the long-term survival is the prevention or progression of this cardiac allograft vasculopathy, because this is a limiting factor why patients need to be transplanted. So that's one of the reasons why the focus of care changes over time. Just to give you an idea of the ISHLT, they group it by age group. You'd see here that the graft failure is still the number one cause of death for the younger adults, 18 to 39. And then, of course, the acute rejection is higher. That's a yellow line, compared to all the age group. The challenge for us as a community, because Penn is not going to be Penn without the patient. It's a mutual, beneficial relationship between the two of us, almost like a symbiosis. We're going to give you all the best care that we can, but you on your other end should also help us. So the challenge for us now is for the younger population, because I think they need, just like I was mentored by Pat, all these young kids need to be mentored too, because most of the graft rejection and the acute rejection that happens to this age group, I think they need some guidance. So now that we know about this, we kind of like see this patient more often in the clinic, rather than every 6 months. We see them a little bit soon, more often than normal. And of course, if you see here too, that in the older population, 60, 69, and of course the 70 plus years, it's not much of an issue. The graph is almost the same as the cardiac allograft vasculopathy is almost the same with each age group. But it's really the acute rejection and primary graft failure that is very prevalent in the younger population. But if you see it also in the cardiac allograft vasculopathy, it's almost similar, but at the older age, because the older age have more hyperlipidemia, more diabetes, they tend to have higher incidence of cardiac allograft vasculopathy. So risk stratification of age group, we established that based on this analysis by the ISHLT.
What's the light blue line? Everything else is...
Which one?
The light blue line.
The light blue line is
There's
like
5 graphs and there's 4.
The light blue line is a reference for the statistical differences from all of the age group.
Okay.
So that's why it's not, the red one is for the cardiac alveolar vasculopathy, the yellow is acute rejection, and the green one is malignancy meaning non-PTLD patients who have skin cancer, lung cancer, and all that are all risk factors. And of course, the blue line, the dark blue line, is the graft failure. And then to compare each one of them statistically, that's the point of reference, the light blue line. And of course, with when we give you medication, it's not just voodoo. It's an individualized medication. You'll probably say that, why am I cyclosporin? Why am I on azathioprine? Why am I on mycophenolate? He's not. Why am I on prednisone? Each one is different. Like with the immune system, each one respond to the immune system differently. And of course, with that in mind, they did a study. This is a European and American study again. They compared cyclosporin and tacrolimus, and apparently there's not much of a difference. When they compared azathioprine and mycophenolate, they have shown that a combination of a calcineurin inhibitor, cyclosporin, tacrolimus with and mycophenolate is better in decreasing progression of transplant arteriopathy, but not much of a difference still. But sometimes patients cannot tolerate mycophenolate. That's why patients tend to be on azathioprine later on. Another thing that's new is not really that new anymore is the sirolimus or the everolimus. Probably some of you guys were in that study of the everolimus in the past. They did study that and they found out that it actually decreases transplant arteriopathy, but not significant enough. So there's lack of additional survival, and there's a lot of major limiting factors with the sirolimus. So that's why it comes with an individualized medicine. Individualized immunosuppression, meaning my medication will be different from him, your medication, so there's no point of comparison because we judiciously think about it before we give it to you. So I was talking so much about this cardiac alveolar vasculopathy. It's probably boring you guys now what it is, but this is what it looks like. So anybody who had a heart attack in the past and had a cabbage in the past, anybody in the audience? Okay. So in your case, there's this plaque. Initially, they could just put a stent into it, and then if it cannot be fixed with stent, that's when they do the open heart surgery and open up those vessels. The problem with cardiac alveolar vasculopathy, that's why it's a limiting factor of graft survival, is that they only go to the distal. We call it distal pruning. See, it's not amenable to the stents. They always go to this intraluminal and epicardial coronary arteries, and this could happen, and it's going to occur to within months, within years. But the main thing about it is we cannot stent this. It's almost like if this is your hand, and all the plaques go to the distal portion of your hands. So we cannot stent those. That's the reason we are very aggressive with your lipids, or aggressive with your diabetes, because are the risk factors that can affect graft alveolar vasculopathy in the future. Of course, you'd see in the picture also that there are also immune problems, like all these cellular rejections. The patient have a lot of rejection. Anybody who had antibody-mediated rejection. All these things will be discussed by Pat later on, and how to. I'm just giving you a background of what it looks like, but all these risk factors are in consideration for our risk stratification strategies. So this is just, anybody here in the IRIS study, the CTOT 11, where they look into the coronaries? Who are the first year out? Okay, so some of you are probably part of the CTOT 11 study where they look into your coronaries and they look into the coronaries and look and measure the thickness of it. So this is what it looks like. So this is a newer version of technology that has been there since a decade ago, but we started to institute it here at Penn, but we stopped the CTOT 11 study already. It's like we're giving rituximab versus placebo. But what this is showing is that they go through a left heart catheterization. That's an example here. At 3 months, they measure the intimal thickness. And this one showing that there's a thickness in the LAD, or the left ascending. And then this one is at 12 months. You can see that that's the lighting is actually that it has progressed. So once I know that there is progression of transplant arteriopathy or cardiac alveolar vasculopathy, we will be aggressive with the medication. This is just the beginning of it, because as I showed you earlier, this will be just the symptom. You can't see it in the CAT scan. You can't see it in the left heart cath. You can only see it with a measurement of its thickness. However, the problem with this is there's only a few centers that can do the IVUS, or intravascular ultrasound. So that being in mind, we just make sure that the immunosuppression medication are taken care of, and of course making sure the diabetes and your cholesterol is well taken care of too. So this comes with this is just an example of what happens to your coronary. So this is your normal coronary artery. And then you have either acute rejection, and then you have all these immunological responses. They all attack that. And then the allo response, the antibody antigen responses. And of course, this is the end result of having transplant arteriopathy. That's why the IVUS, the one that I showed you earlier, this one, measures this thickness. And once it's thick, we start aggressively with the medication. But there are a lot of risk factors making this transplant arteriopathy. And of course, we call it the art of how to fix it, the art of focusing on the adherence, and of course, the restoring health, and of course, the annual test that we've been doing for the last several years. So, my friend and colleague, my mentor, Pat Stutman, will be discussing that, and hopefully, and then we'll be answering your questions later on. So, ladies and friends, let's welcome Pat.
I need a little technology. Here. I think I can handle that. Thank you. It's so good to see all of you out of the clinic setting, always. So we're going to talk a little bit about, as Marie said, the change in focus of care. And in the beginning, those of you who are out in your first year know that we're focusing right now on rejection, on frequent testing. We're seeing you a lot. You're looking at recovery, rehabilitation, return to life, return to work. But after a couple of years, our focus changes a little bit. We worry less, for the most part, about rejection. Rejection can occur anytime after transplant, but we don't usually see it in most cases after 2 years, typically. Which is why, and then there are some outliers, and we all know if you're one of them, but typically it's not as common after 2 years. When I first started this, and I think Menno will remember, we used to biopsy forever. We biopsied you every 6 months forever. And then we started to think, you haven't had a rejection in 15 years. What are we doing here? So we changed it, and we went to 5 years. And then, whenever we make a change, we review the data before we make the change. We saw our data was great with 5 years, stopping at 5 years, so we went to 3. Again, we reviewed our data at our yearly retreat, every 2 times a year retreats, and we moved it to every 2 years. Now we stop biopsies after 2 years, routine biopsies. We always reserve the right to biopsy if your clinical condition changes, if you have symptoms, or if we make a major change in medications. But routine biopsies stop after 2 years. And most late rejection is associated, unfortunately, with noncompliance. And it means not taking medications as prescribed. And I think that in the beginning everyone was so vigilant and they're so happy. But we're almost a victim of our own success in some cases because people feel great, they're happy, they're busy, they have a great life, and oh, the pharmacy doesn't have their tacrolimus, or the mail order didn't deliver their tacrolimus or their cyclosporin. It's like, oh, I can wait a week without it. Well, you can't. And I've been trying to tell people this when I see them in the office now, and everybody says, oh, I would never do that, I would never do that. But unfortunately, we've seen some people who just get a little cavalier, they feel so great, and they can, oh, I can, my copies are too expensive, I'm going to cut back my doses and make it last a little longer. And this is where we run into trouble. We have a wonderful team. We're on call 24/7. This is my week on call, so if you call this week, you'll get me. And call us at any time. We will not let you do without your medications. Our social workers are incredible at working things out. So don't ever do without your medications for any reason. You know, that's sort of the take-home point. And the other thing is to call us. You know, you don't care how many years out, if you don't feel well, we want to be called. And that way we can, if you do have a rejection, we can catch it early. And that's actually the key. So, let me just see what the slide is. Let me just talk a little bit more about rejection. There's two different types of rejection. One is cellular rejection, and that's typically what we hear in the first year. You're all familiar with the 1R, 2R, 0. And that's a cellular. That's where basically your white blood cells attack your heart as a foreign body. They don't know it's yours. And that's what we worry about initially. But in the cases where medications are held, missed, or doses are reduced inappropriately, it causes a different kind of rejection, which we call antibody-mediated rejection, or AMR. And with that, it's your body, as your levels of your drugs fall, your body revs up its immune system and makes antibodies towards your heart. That's a little bit different. It's a different type of rejection. It's more associated with hemodynamic dysfunction. So you're seeing people sicker and with heart being damaged, more with antibody-mediated than with cellular. So that's something that we're concerned about. The treatment is also different. Usually it's not treated at home like some of the cellular rejection. It's mostly treated in the hospital, and the treatment can take weeks. Sometimes we see the ejection fraction or your heart function fall with this kind of rejection, and sometimes it comes back, sometimes it doesn't quite come back. So it's really a serious matter to just keep in mind, take your medications no matter what, and we're always here for you. Okay. To answer any questions or anything about medications. And again, it also says, call us when you don't feel well, because we like to get things on things early. Okay. So, like Maria talked about, well, Jane did this. Prevention of change in focus. What are the things we focus on now? Prevention and early detection of CAV, or cardiac allograft vasculopathy, which Maria talked about, and that's really important. It's the #1 cause of problems with the cardiac allograft or your transplant. The second one is controlling the effects of long-term immunosuppression on the body. Now, I think we all know there are some. Infection, cancer, damage to other organs such as kidneys, bone marrow. We use a cautious decrease in immunosuppression, which we'll talk about. Cancer prevention and early detection is really important for the general population, more so for transplant patients, because your immune system isn't like the immune system of a normal person. So you are more susceptible to certain types of cancer. General health, we'll talk about general health, is really important, and fitness, of course. And to go in the prevention and early detection of coronary artery disease in the transplanted heart, again, standard statins. Everybody, statin is a class of drug, the most common class of drug to treat high cholesterol. You may know pravastatin, atorvastatin, rosuvastatin, simvastatin. These are all the drugs that we call statins. Some people say, my cholesterol is normal. Why do I need a statin? Anybody in that condition? Anybody say that? Yeah. And it's because the statin drugs have a protective effect on the coronary arteries of the transplanted heart, even in the absence of high cholesterol. So even if you don't have high cholesterol, these drugs are going to have a positive effect on your heart. It's an anti-inflammatory effect, and so that's why all of our patients should be on a statin. Of course, everyone's individual, and there are individual cases. Managing these drugs in heart transplant patients is a lot harder than in the general population because of drug interactions with your immunosuppression medications. So we sort of have a different approach than an outside cardiologist or an outside primary care physician would have. We have to start at much lower levels of these drugs because of the interaction. We also go up very slowly and very cautiously, followed closely with blood tests and also your input. one of the biggest side effect would be leg or muscle cramps, muscle cramping and weakness, which is more likely to occur in you because of the immunosuppressant medications. So where a normal cardiologist might start atorvastatin, might go to atorvastatin 40, we would start out at 10 and gradually work up. Okay. Some people can't tolerate them, and we've actually gotten a little tricky now, and we say, okay, you can't tolerate pravastatin 10 milligrams once a day, so let's try pravastatin 10 milligrams twice a week. And then let's go to 3 times a week and see how we do with that. We also learned from our lipid specialist colleagues that sometimes coenzyme Q10 can help with statin tolerance. And that's an over-the-counter substance, so it really doesn't have much in the way of effect, so we try that with people too. If we really have trouble and people can't tolerate these medications, we might call on our colleagues at the lipid clinic who are also very good. And the lipid clinic here, being at Penn, knows transplant, and they know all these issues that we have. We also have a lot of problems with insurance issues with certain statins. The insurance companies want you to take the old, cheap drugs, and they're not as good as some of the new ones. So Patty Paderis, our nurse, spends a lot of time on the phone with insurance companies trying to prove to them why you need Crestor instead of simvastatin, for example. So it's a really important thing, and we do spend a lot of time on it. However, the one very dangerous side effect is the statins in anyone, but particularly within our population, can actually have a problem called rhabdomyolysis, which is actually very serious. And if you have muscle cramps on a statin, you need to call us. We'll do blood tests. If it's very severe, and we need to know about it, we need to stop it right away. If you call us with muscle cramps, we'll often tell you to stop the statin, and then if the muscle cramps go away, then we know that's it, and we'll go on to a different drug or a different dose or try something differently. But if it doesn't, then we'll say it's not that. But it's very serious. So if you really have severe muscle cramping or pain and weakness, that can be very serious. Also, we just do standards of, like Maria said, standards of care. We control blood pressure, weight control, and exercise, also to prevent coronary disease. We do screening. Everybody complains about their dobutamine stress echo. It must be nasty. How many people have dobutamine stress echoes? Yeah. It's the best test to detect transplant coronary disease in the transplanted heart. It's actually the gold standard. So that is why we do that test. We do it once a year. Some centers actually do left heart catheterizations every year. That's actually, we think, overkill, because this test gives us a lot of knowledge, and it really makes us, we're confident in that test. And some people can't take it for certain reasons. Some people really have a bad reaction to dobutamine. Some people have high blood pressure, are on a beta blocker, and if they hold their beta blocker for the test, which is what they're recommended to do, their blood pressure is too high. So not everybody has a dobutamine stress. We use the nuclear stresses, and they're okay too. But dobutamine, if we can, if there's no reason not to do a dobutamine stress echo, that's our test of choice. If that test is positive or equivocal, we're not sure, then we would jump in and do a left heart catheterization. If someone has symptoms, you might have a left heart catheterization. And also another important point, we always used to say years ago when we first started that transplant patients don't get angina. Did anybody ever hear that? Yeah. Okay, we're finding now as people are out for a very long time that they can actually have chest pain that comes from their heart or angina. Because the nerves that are cut at the time of transplant actually can regenerate. So if someone's 2 years out from transplant and they have chest pain, chances are it's not their heart. But call us anyway. But if they're 10 years out from transplant, it might actually be. So those nerves can regenerate and people can get chest pain. Even outside ERs will say, oh, I know that your heart transplant patient can't get a chest pain. And I say, well, it's 15 years out, it is possible. So that's just an interesting fact that we were learning. Okay. Treatment. As Maria said, most arteriopathy is a thickening of the wall of the artery, and therefore you can't stent it, you can't bypass it. Occasionally though, I don't know if some of you have had stents after transplant, occasionally there will be a discrete blockage in the artery and we can't stent it. In the rare case we've even had coronary artery bypass grafting in a transplant patient, but not often. But it does happen, and sometimes that is used if we certainly can. A medication that is known to prevent the progression of transplant arteriopathy is rapamune or sirolimus, and we will try to use that in someone if possible. If we see them developing the disease, we'll start rapamune. That's a little complicated because rapamune, we don't like rapamune with cyclosporin, so we have to decide what to do with that because the effect of those two together can hurt the kidneys. Some people start rapamune and can't tolerate it. It can cause severe edema. There are other side effects that it can cause that are prohibitive. The nephrologists don't like to use it above a certain creatinine level, so we have to consult with them if we want to start it. And so it's kind of complicated and very individualized. But rapamune is, right now, the only thing we really have to treat this disease other than preventing it. And people who are at risk for frequent rejections, particularly antibody-mediated rejection, CMV, people who have had long CMV infections, we are more vigilant with those, and also the standard people with the high cholesterol, those kinds of things. Okay. Effects of long-term immunosuppression. It's always been a balance from day one, balancing infection and side effects with rejection. And it continues as time goes on. We always want to use the least amount of medications possible. What works, the least amount. I worked with Dr. Brazina, she's my mentor, and for years she would always say, let's cut it down, what's the lowest we can go and still protect the patient, and that's always been my mantra now too. As time goes on, less immunosuppression may be indicated. For example, when you first come out of transplant, we want your tacrolimus level around 10 to 12. After 2 years, we like 5 to 8. There are general guidelines. We have individuals may have a little bit of difference, but we use a lot less immunosuppression as time goes on. When we wean prednisone in a lot of people, not everybody can, but we try very hard to wean the prednisone either off or to 5 milligrams. And the cellceptor azathioprine, we also look at that. So basically, every time you come in for a visit, we actually review your medical record before you come in. So we walk into the office, we know what's been going on, we have refreshed ourselves about your history, and we look at your immunosuppression every time and say, what's going on with you? Do we need to make any changes? When we do cut down on immunosuppression, it's very thoughtful and very individual based on the big picture of what's going on with you. For example, we'll talk a little bit later about skin cancer. If someone has a lot of skin cancers and they come in and tell us this on their 6-month visit, we're going to look at their immunosuppression, and if at all possible, we're going to make downward adjustments in it to help them fight that skin cancer. The same with any type of cancer. The same with an infection. If someone is getting pneumonias a lot, we're going to look at that and say, what can we do to lower the immunosuppression? Our infectious disease consultants, that's the first thing they always say when we consult them with an infection. Can you lower the immunosuppression? So we work together with that. When we do make a change in your immunosuppression, if we do make a decrease, we'll ask you to come back in a month and we'll do an echocardiogram and an office visit. And that's just our way of assuring that you're tolerating the decrease. So it makes more frequent visits, but very important. Effect of the immunosuppression on the other organs, I think Jim alluded to it, and we all know kidney function is not normal in anyone who's been on these drugs for many years. That doesn't mean you can't live a great life with it and it won't affect you, but we really have to watch your kidneys closely. And even though your kidney function may be great on a day-to-day basis, if you have any kind of an insult, sometimes we see a bump in your creatinine and your kidney function goes down. For example, somebody has a GI illness, they have nausea, vomiting, diarrhea, they get dehydrated, they come in, their creatinine, which is normally 1.5, is now 5. Not unusual to us. Doesn't scare us. We know we can fix it. Give them fluid, it gets better. But it just shows us that the kidneys aren't normal, but they can do well with a lot of nurturing, and that's what we do. That's why whenever we make a medication change, we follow it with a blood test. It's a lot of blood tests, but they're really important. If we adjust your tacrolimus, your cyclosporin, your lisinopril, enalapril, Cozar, any of those medications, we're going to follow it with a blood test because we're so protective of your kidneys. Really important. Drinking fluid, drinking water. When you're in heart failure, everybody wants water, they're thirsty, and we tell them not to drink. Then we give you a transplant, and after you're recovered from your massive edema in the first couple of months, then we say, drink, 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 and nobody's thirsty. Okay? It's been an ongoing problem. We can tell a lot of times who drinks a lot of water and who doesn't. And it really makes a huge difference. It makes a big difference. We continue to avoid medications that can affect kidney function. Unfortunately, ibuprofen, Motrin, Aleve, they're great drugs. Not when you're taking cyclosporin and tacrolimus or sirolimus. So our patients need to avoid those drugs. And that can be a problem because if you sprain your ankle, it's the best drug, ibuprofen. But it's really in your best interest not to take those drugs because that's another reason that could really send your creatinine up. So very careful. We consult nephrology a lot. We like to have them on board. We work very closely with our kidney colleagues. And if we see someone's creatinine is rising and we've done everything we can, we'll get them on board and help us. And to help us with it. So we may ask you to see a kidney specialist just as a precaution, just to give us an extra boost in protecting your kidneys because that's so important. Another thing we look at is bone health. We give people massive doses of prednisone in the beginning, and then we have to think prednisone contributes to osteoporosis or osteopenia, which is the beginnings of osteoporosis, not full-fledged. So whenever we have people on high-dose prednisone, they're at risk for it. Now, women, of course, after a certain age, are at risk for osteoporosis, but so are men as they get older, and especially a man who's been on prednisone. So we do DEXA scans basically every other year. We recommend DEXA scans basically every other year. However, we're going to talk a little bit later about not doing the DEXA scans here. We're great and we really do a good job, but we don't know the latest on osteoporosis management. We're really not good at that. So we would like you to go through your primary to do that. They're up on the latest because that field is changing a lot. There's a lot of really good new drugs out. Wound healing. We'd like to know whether you're having surgery because some of the drugs affect wound healing. And if you're going to have even some surgery, which you might think minor, like a little skin removal, we would like you to let us know because we may have to make adjustments in the medications. We watch your liver very carefully because these drugs can affect your liver and your bone marrow. The azathioprine, the mycophenolate, they can affect your bone marrow, and after time, sometimes we see low white blood cells, low hemoglobins, you're anemic. So these are all the things that we watch every time we see you, every time we do this. Okay. Effective immunosuppression, cancer. Number 1. Skin cancer is very prevalent in the general population, especially for those of our certain age where we used to lay out in the sun with the baby oil and no sunscreen. But it's much more prevalent in the transplant population. The immunosuppression keeps you from being able to fight the skin cancer. All of our patients, no matter what their skin tone, we ask them to see a dermatologist once a year. Okay, very important for a full body skin check once a year. Risk factors, again, fair-skinned and sun exposure. I believe even like one bad sunburn put you at risk for skin cancer. And I think most of us, again, after a certain age, have been sunburned. It can be serious. Some people have multiple areas of skin cancer and they're recurrent. And it actually can become systemic and affect your entire body. And so that's really, we can't emphasize enough how important going to a dermatologist and having your skin checked. And any suspicious lesions biopsied or removed. We have a great transplant dermatology here. And we really like to work with them. First of all, they're very easy to work with and they're very nice. But also they understand the effects of immunosuppression. And as soon as they have a skin cancer on someone, they're calling us right away and saying, okay, what can we do with the immunosuppression? Can we cut it back? And we work with them at doing that. It's really important. Again, drugs that interfere with wound healing. We had, if you're going to have surgery, Mohs surgery is a common surgery for removal of skin cancer. It's deeper than just removing a little bit from the surface. And we really need to know if you're having that because we may need to adjust your medications to allow for wound healing and prevent infection. Okay. It's always a delicate balance when someone is a rejecter it has a lot of rejections to balance the side effects versus the rejection. So it's an ongoing process. We have what we call PTLD, which is post-transplant lymphoproliferative disorder, which is a cancer. It's a lymphoma that comes from immunosuppression. So people on immunosuppression can get this. It can be very subtle. We are very good at looking at it. If someone has some vague symptoms, it's always in the back of our mind. We'll do CAT scans. It actually, you can see lymph nodes, enlarged lymph nodes. We'll do a CAT scan and we see enlarged lymph nodes in the chest or the abdomen. We always think PTLD, and it's always in our thought. So we always investigate it further. It can be treated sometimes with only decreasing the levels of immunosuppression. Sometimes that'll do it, and a lot of people that will do it. That's all you have to do is cut down on the immunosuppression. And then there's various levels of chemotherapy that can be used if that doesn't work. We also have a great oncologist here who works with us on this, and we work together and we battle over how much immunosuppression we can cut, but it's a very collegial relationship. Other cancer screenings, breast cancer, women have to get mammograms. They may or may not, we're not sure if transplant increases the risk of these other kinds of cancers, we don't know, but we screen for them anyway. Prostate, men should have a PSA, prostate blood test, and an exam every year. Colonoscopy, it depends on the individual, how often it needs to be done, but it should be done at age 50. Sometimes we recommend it earlier in our patients because of immunosuppression. Lung cancer, we do a yearly chest x-ray, and unfortunately we've caught some lung cancer. The good news is that lung cancer that's caught incidentally on a routine chest x-ray is a lot easier to treat and has a lot better prognosis. Smoking on immunosuppression is deadly. People who return to smoking, and there are people who return to smoking after transplant. It's really serious for a lot of reasons. Lung cancer, we just see it's almost if you're smoking on immunosuppression, when will you get lung cancer? So it's really important not to smoke for various reasons. And I should have mentioned that as a prevention of the transplant arteriopathy as well. Of course, smoking is a big thing. Okay. Just a little bit about the different types of rejection. They can occur at any time. The antibody-mediated rejection, cellular rejection, and cardiac allograft vasculopathy can occur at any time, which is why we need careful follow-up. The summary of general health maintenance, we've divided these up as to what you will do with your primary. We really would like to stress the point that we are subspecialists and we're really good at what we do. However, there's a lot of things we're not good at, and we can't keep up with everything. So we would really count on primary care physicians in the community, in your area, to help us with screenings. With your primary care, vaccinations, tetanus, it's the DPT, which is diphtheria, pertussis, and tetanus is important. Pertussis is on the rise, and we actually did have a transplant patient with pertussis, which is whooping cough. Flu every year. We've done studies, and the influenza vaccine does not interfere with it does not cause rejection. There was a feel that it would rev up your immune system. Multiple studies have been done. Dr. Blumberg of infectious disease, and I did a study years ago, our own study, has no effect on rejection at all. So we recommend influenza vaccines for everyone. We also recommend that your family members get the influenza vaccine every year, people you live with, if they can, because we don't know whether you respond to it or not because of your immune system, but your family members will, and then they won't bring it home to you. And pneumococcal vaccine in our population is every 5 years. And we ask that you not get any live vaccines. So that is, don't ever get the flu nasal spray. It has to be the injection. And no live vaccine. The shingles vaccine you hear a lot about now is a live vaccine, so we can't have our patients get it. Unfortunately, because shingles can be a problem. Mammograms, breast exams, gynecological exams, prostate cancer screening, DEXA scans, colonoscopy, dermatology, dental. It's very important to go to the dentist, and you should let us know whether we give antibiotics before going to the dentist is an individual situation. The American Heart Association does not recommend that transplant patients get antibiotics prior to dental work. Our program says that it's an individual thing. We'd like to look at your echocardiogram and look at your valves to decide whether you as an individual need the dental screening or not. Controlling diabetes, vitally important. But again, it's not our area and we're not that good at it. Vascular screening. Those of you who have had ischemic heart disease, heart attacks, bypass before transplant, also are at risk of having that same vascular disease in all of your vessels. Your legs, peripheral vascular disease, your carotids, the blood supply going to your brain, so, and your aorta and your abdomen. So people with that history would need to be screened on a regular basis, and your primary can certainly help with that. If on the other hand we find a problem, you're certainly willing to come, we'd like you to come back to Penn and we'll set you up with the appropriate specialist if there is an issue. Thyroid, we have a lot of people with thyroid problems. We don't like to handle that. I mean, we prefer you to have your primaries do that. And sleep apnea. We see a lot of sleep apnea. People with snoring, not getting enough air or oxygen while they're sleeping. It causes a multitude of problems. Daytime sleepiness is a symptom, but it can also cause a lot more problems too, with your heart and your blood pressure. And so it's really very important. That's one of the things we'll ask you about. We'll screen for the possibility of sleep apnea when you come on your visits. And you can certainly do the test locally. Or you can do the test here or locally. It's up to you, but we will definitely screen for that because it's a problem that's a lot more recognized these days. The things that we do at Penn is blood tests, your kidney functions, liver functions, and lipids. We do an echocardiogram. We prefer echocardiograms here only because our cardiologists are really used to looking at the echoes, and in other areas they're not. In other hospitals, the anastomosis where so the heart in looks a little different, and people will say, oh, you have a blood clot in your heart, and really it's not, it's just a suture line. So it's kind of a real specialty. So echocardiograms, if at all possible, we prefer to do here. We'll do EKGs, electrocardiograms. We will do chest x-rays. Exercise or stress tests we like to do here. And of course, biopsies and right heart caths we do here. Okay. Just in summary, it's really important. We screen every time you come in. I said that before you come in, we've actually reviewed your record. So we know, we have refreshed our memory as to what is going on with you. So if you've had a lot of rejections, we'll be more vigilant for looking for coronary artery disease. If you've had antibody-mediated rejection, then we'll also be very careful with watching you. And we also, the CT4 staining is how we diagnose antibody-mediated rejection. It's on a biopsy. They take an extra piece and they look at it in a different way. Okay. We also look at things like the sex of the donor, history of the donor also. We take that into account as determining your risk of developing this disease. Higher donor age can do it sometimes, but a lot of times we'll try to match the donor age with the recipient age if at all possible. And the other things we mentioned, hypertension, if you've had ischemic heart disease before, that may put you at more risk, high lipids, hypertension, or a CRNP infection. So we're hypervigilant with you. And I think that's it, but we're really open for questions.
I was curious. On your license, sometimes people have organ donor.
Yes.
If you are a heart transplant recipient, can they reuse your heart for the...
That's a good question, and it's a very nice question, and we get it a lot. No, we can't. We don't reuse your heart. But we always say, put that on your license anyway, and let the organ procurement experts decide what can be used, because we may be able to use something else. Absolutely. So please still put it on and let the gift of life people decide what they can take. Because we have had many patients who have donated after transplant their corneas and other things. So I would still put it on. But we don't use the heart. Yes?
What are the symptoms of the PTLD?
PTLD. So it's like a lymphoma. So any symptoms of lymphoma. You want to go up here and help me answer the question? So a lot of times it's just fatigue, fevers, very often fevers, pain in different areas. It depends on where the PTLD is. Yeah.
Just flu-like symptoms is
Yeah.
the beginning of it.
It can be very vague. It can be very fevers, chills, night sweats, unexplained pain or fatigue, It can be very bad.
Largely of the lymph node.
Yeah, I mean, actually, you can actually see, we had one young man who came in and it looked like he had two balloons on his neck. And that, we just looked at him and said, oh, we know what you have. And that's what it was, he's getting treated now. But enlarged lymph nodes, basically. And I mean, it depends on where it is. We've had people with it in their intestines, and they've come in with the gastrointestinal bleed. So it depends on the location of it. Which is why we like to, if you're not feeling well in any way, we'd like you to call us, because that's always on our mind. But they're basically the symptoms. And another thing is, forever, it doesn't matter how far you're out, always call us. If you're getting treated for pneumonia at your outside hospital, call us. We want to know. Maybe if you're getting better, it's okay, you can stay there. But we had a man being treated at his outside hospital for a month or 2 months, and he was on 3 different types of antibiotics, and he wasn't getting better, and he finally came to us, and it was not a bacteria, it was a very serious fungus, and he was very, very, very sick for a long time. So we like to know what's happening with you. Even if you're out a long time, just give us a call and say, hey, I've got pneumonia, I'm getting treated, and we'll say, okay, if you don't get better in a week, call us. So we always like to hear from you, no matter how far out you are.
You got a question?
I have a question about the virus that young children are having.
Yeah.
Is that something we need to be concerned about?
Yeah, well, actually, we've been thinking about that. It's most common in children, but we don't really know whether an immunosuppressed patient would be like a child to get it. So the bottom line is, call us if you're not feeling well, okay? Basically, if you have, it's a cold. We like, if you have a cold and you're not getting better, anytime if you have any problem breathing with a cold, it's not normal to have trouble breathing with a cold. So if you do, give us a call. But all we can say, and our infectious disease consultants have, approved this, that call us if you're not feeling well, and continue good hand washing and good common sense skills. But we really don't know whether we're going to see it in transplant recipients. It certainly is possible. Yes?
I was just wondering, the different rejections, what are the symptoms for them?
Well, very often cellular rejection, which is your typical 0, 1R, 2R, very often it has no symptoms, which is why we need to biopsy. But if rejection of any kind has a symptom, it's basically symptoms of heart failure. It can be anywhere from just fatigue. I'm more fatigued. I'm really tired this week. I go up steps and I was never short of breath climbing a flight of steps. Now I am. So it can be very subtle symptoms of heart failure. Swelling, although swelling can come from a lot of things, but that's one of the possibilities. Edema, shortness of breath, fatigue. They're basically the signs of it. And they tend to be, or signs of full-blown heart failure. You've all been in heart failure. So, you can't lay flat. You wake up at night short of breath. You just really, basically signs of heart failure. Yes?
I was told that when my grandchildren get their shots, if they get a live virus, I need to avoid them for 5 days.
They're bodily fluids.
But my son's pediatrician was vehement in saying, don't let your father-in-law near him or your father near him for 2 weeks. Is that because they don't know the transplant?
It could be. And it's also...
The 5 days is what you still say?
Yeah. Don't you think? Yeah. And I think there's not as many live vaccines as there used to be. I don't know what they're doing for the polio. Polio used to be the oral, and that was live, but I think now the vaccines for polio are not live. But and it's mostly bodily fluid, so you can certainly be in a room with them, but don't change their diaper or hold them and have them drool over you. I mean, you say stay away.
So it's only bodily fluids.
Well,
okay.
We say stay away just to be cautious,
Right.
but technically, it's basically they secrete it in all of their fluids, and babies, little kids, drool and so it would be not unusual.
So it's nothing airborne, it's the body fluids.
Yeah.
Thank you.
Yes.
Dr. Stutman, you mentioned muscle cramping.
Yes.
If it's just a mild, like every now and then, you've got it in your calf or your toes will start. Is that anything?
Yeah, well, we all get muscle aches occasionally, but
cramps.
The cramps. Okay, but we like to, if it's anything that lasts, not just an occasional cramp, all right, that's fine. But if it's occurring frequently, we like to know about it, because sometimes we always like to know. So give us a call. But if it's severe, absolutely, it's an issue. Sometimes the tacrolimus can cause muscle crampings in fingers, sort of cramping, and we hear that a lot too. So it could be a medication effect, a statin or not a statin. But if it persists and is severe for a day or so,
No difference, so yeah, I'll be right on top of it.
Okay, good.
Could you just clarify again with the disease with the arteries? You mentioned how there's a test that looks at the thickness if you're in on that study. How do you know whether that happens? Like what kind of test is there that happens to make sure your arteries are okay? And how often do you do that?
Very good question. So with the transplant arteriopathy, usually occurs any given, like most likely the 3rd to the 5th year. And as I mentioned earlier, it's a distal pruning, and this is the one I'm talking about. The intravascular ultrasound, which we are not doing here at Penn. We were doing it initially with the CTOT 11 study, but there are some issues with the cath lab, and also since we're not being funded anymore. But this is...
Insurance don't want to pay for it.
And there's also a problem with this because it give you a dye, because you also have a left heart cath. They use a dye, look into the coronaries first. Once they have that coronary visualized and see that, oh, there's a thickening there, let's put in a probe. And then putting a probe inside that coronary artery, and then they'll measure the thickness. There's actually, there's measurement of the thickness. You see it lights up. So that's why this is the 3rd month and this is the 12th month. You can see that the lighting, the thickness is thicker. So just based on this, we can put a patient on sirolimus just on the basis of this test. In our case, we're doing the stress test. So when we do the stress test, when it's positive, we do a real left heart cath where they look into the coronaries. Of course, what they're going to see is just this when they do the coronaries, because usually it's in the distal area. But if it's like really blocked, if all of this is blocked, they could still stent it. They could still also bypass it if it's like a big major vessel. But if it's in this distal area, we just treat with medicine. But as of now, that's where we're doing stress tests every year. And this is the one that we are checking for now. But in the future, if the insurance will pay, then we might have to do the IVUS or the intravascular ultrasound, and where they could really measure the thickness of it. So early on, you can see that the plaque, so the plaque is just building up, you can measure it already. That's the bottom line. You see it right away. Unlike when you do the left heart cath, it needs to be a big blockage already before you see it. That's why there's a problem with detecting transplant arteriopathy early on.
So you just do that test once a year, like on your first year?
Forever.
That's the type of echo then?
So we do a stress test every year for life. And if you have a positive stress test, then that's the time we're going to do a left heart cath.
Okay, thank you.
And for those of you who are in your first year, dobutamine stress test is you go to the echo lab and they do a baseline echo, and then they inject you with a medication called dobutamine, which simulates stress of exercise. It raises your heart rate and simulates stress. And then they do an echo following the administration of dobutamine, and then they can see how your heart reacts under stress.
Maria, can you go back to the sheet with the CAV stats that you had? Because I wasn't quite sure what it was telling me.
Which
No,
slide?
keep going. You had a slide
No,
with
the one with this.
the ages, yeah.
This one, okay. So this one is just saying that,
No, I'm sorry, the one that was,
this one?
this one, yeah.
Okay.
But I see like 68 point, like for renal dysfunction, 68.4% within
Yes.
10 years.
That means there's a lot of people who's going to really going on dialysis and all.
And the CAV says 50.1%, so is that
Yes.
saying within 10 years you're going to get it?
Most of the people
One out of
in the
two are gonna
whole,
get it?
yes, in the whole, this is a registry from United States and of course Europe. So among all the responders and they put in the data, all the centers that has put in the data have revealed that there is a 68% chance that 10 years that they have renal dysfunction. Most of you will probably know what chronic kidney disease, and of course there are stages of chronic kidney disease. You might be chronic kidney disease stage 3, so you'll be listed there. That's why the numbers are so high, because you might be chronic kidney disease but you're stable, and then what we do is decrease your immunosuppression and then make sure that you're, sometimes some of you are on prednisone, you might notice you're on prednisone, in order to keep that kidney function or that tacrolimus or that cyclosporin at a lower level. So that's a preventive measure on our part to decrease this incidence of having that higher incidence of chronic kidney disease.
So Maria, when you say chronic and stable, you don't mean dialysis,
No.
you mean medication, stable by medication.
Yeah, you need to be stage 5 to be end-stage renal disease. So if you're stage 3 or stage 4, meaning you're still urinating, you're categorized. That's why the number is so high. But there's only a few people that is stage 5, and the stage 5 are the one that goes for hemodialysis.
I mean, many our people they're stable, and they might stay at stage 3 forever, stay at stage 4 forever. So just because the toxic effect of the drugs is less as time goes on, so they might be a stage 3, and then as we come down on the drugs, you just stay there, and it doesn't get any worse.
And looking at the CAV stat, 50.1%. Now that you're aware of that and you're being aggressive about it,
Yep.
you would, I guess you can't predict with a crystal ball,
Yes.
but you would say 10 years from now, that number might plunge because
Yep.
you're approaching
Right.
that.
Yep.
Thank you.
And also, people have it and live perfectly fine with it too. So I mean, think of all the people in the general population who have coronary artery disease, who have had a heart attack, and then go on and live for a long time in an active life. So it doesn't mean that you're all of a sudden going to be sick with it.
Thank you.
Now, relative to what you were just talking about, if you have not had a heart attack and you had some other cause for your heart transplant, me being an example of that, how does it affect those numbers? Or how does it affect the likelihood of that?
All right, so these are the risk factors. So the ischemic cardiomyopathy is just a risk factor. So if you have high lipids, so these are the other risk factors that we're checking. So of course, immunologically, if you have several rejection, if you have antibody-mediated rejection, if you have a presence of immunofluorescent in that biopsy, and if that's a risk factor itself. So we are very vigilant of these people. And then also people who have hypertension, several episodes of CMV infection, your lipids are not well controlled. Of course, ischemic cardiomyopathy, another thing. And of course, your donor history. We usually look, because we always match you. If you're 65, you might get like a 62 or 63-year-old heart, but not really most of the time. But if you got it, we make sure that there's that we look at the coronaries and it's good. And then usually we will do probably a left heart cath in a year, just to double check if we have an older age heart. Because we already know that at that age, regular patients, meaning non-transplant patients, can have coronary disease. So we would just look and have a left heart cath. So some people will have a left heart cath, most of the people will just have stress tests. So knowing all these risk factors, we can pinpoint, okay, Mr. X and X is a risk factor. Let's strategize. Let's put this patient early on in Rapamune. Let's strategize making his CMV, like we'll prevent CMV infection by decreasing immunosuppression. So knowing all those risk factors help us to kind of like make an individualized immunosuppression medication and individualized care.
Yeah.
Fungal infections. Supposedly, when you go swimming, we're supposed to go in the ocean or chlorinated pools.
Right.
I had an occasion where I fell backward into a pond.
Ah, I
And when you
remember.
fall backward into the pond, everything goes up your nose.
I remember.
You've got a lot of stuff inside you. So
Yes.
my immediate reaction was to take 3 or 4 shots of whiskey and kill all the germs.
Well, at least it made you feel better.
And then I took the probiotics, and I filled up on a whole bunch of them, and I said, well, I killed it in the stomach. If I didn't get it there, I got it with the
Yeah.
yogurt.
Okay.
I just wondered, what do you do? You
What
fell.
do? You call us and we do what we can. You know, it happens. And
But
you know what? You're here to talk about it. So.
After 2 or 3 months, you realize, I guess it didn't affect me.
Yeah. And again, that's just a precaution. Not everybody who goes in the pond gets.
No, I just fell backward and off the dock into it.
We don't fix clumsiness, right?
When is the new future, they're making organs now. And I don't know when this is going to ever, I mean, they might have organs made in 2 or 3 years, but they won't be on the public till probably 15 till they're proven.
Yeah.
But for younger people, there's always a chance of, if you've been transplanted now, can they take that transplant out and have one being made? So your heart is made now artificially out of your own genetics.
Oh, that would be great.
And can they take that other heart and put the new one in since it's yours? In other words, rejection medicine is what's keeping everybody sick. It's the medicine. Believe me, it does a lot of damage. And you still have skin cancer. I'm a dermatologist's best friend.
You're talking about regenerative medicine. So actually, right now, there's actually scaffolding wherein they put in your stem cell. So there's actually a mice in Mayo Clinic that they put in, like, they scaffolded a mice heart, put in a stem cell, and then it pumped and worked. So now they're trying to do that with humans. So in the future, your suggestion might be there. There's a lot of studies about regenerative medicine wherein your own body, your own stem cell will create its own. Actually, here at Penn, when they put in a VAD, they can put a stem cell and see if it's going to work. It's still in the early phase, but if you have an acute myocardial injury or a heart attack, they put in that stem cell, and then hopefully it will regenerate. That's why there's a lot of future in regenerative medicine, but for now, we'll take care of you guys. How about Tanya?
Yeah, sure. I heard different things as far as being around people that have had different types of cancers and them going through chemotherapy and radiation. Is it something being on the immunosuppressed?
Well, actually, most of the time, our patients are probably less immunosuppressed than someone getting chemotherapy. That's pretty intense. And unless you've just gotten massive treatment for bad rejection with thymoglobulin or something like that, you're not as immunosuppressed as those people. So they're more cautious. There's more precautions for cancer patients.
Thank you very much. Let me add a couple of things to emphasize what they said. First of all, you guys, you're anything like me. You know, you have something going on, it's going to go away in a couple days, right? So don't bother them. And so after 7 days of pain in the leg where I couldn't even walk anymore, I finally had to go to the foot doctor because I didn't want to know what he was going to do. He said, Jim, we don't do that anymore. He said, give me a pill, it's gone in 2 days. I spent 7 days in pain because I was a guy and wouldn't call. Okay? now let me give you a couple other secrets. First of all, on the immune stress test, here's a secret. You guys don't know about this. You know when they get to the last part, they're trying to get you up to that target number?
Yep.
Okay. Think of your partner and the best sex you've ever had. Close your eyes, and every time it jumps right up. Hey, it's much better than that squeeze bubble, you know. Anyway, my wife doesn't know about that one. But the third thing I want to mention to you has to do with finances. Last year, with all this change in the insurance and stuff, I ended up switching to, well, my wife went out of work, okay, so I had to get Medicare type insurance. Got that. And of course, someplace online, I learned that I did not need referrals. 3 months later, after not paying attention, I saw the bills come in, and we were in the $30,000 range for these standard tests we do all the time. I mean, I panicked. It was my home retirement fund. Yeah. And the net result was, I asked around, I called here, Medicare, they're not very flexible. I had nothing to lose. So I wrote a letter saying, hey, I've been stupid. I mean, I said that. And I said, we're up against it, and here's what happened, and anything you can do to help. By the time I got through, 3 months of those bills got back to what it should have been if I had a referral. I mean, that $30,000 got down to something like $500. So don't ever give up on that stuff. Do not screw around with your medications because you can't afford them. A friend recently was on a cruise of some type, and they got delayed someplace and got stuck. And he didn't have his medications for that much more time. Called the hospital. Somehow they got medications over in some other country. They will pull a miracle for you. Do not screw around. Okay? It's that important. And so all of those things. And yes?
I like your point for the insurance. I would like to say that any kind of change of insurance, please call us. We have our financial service coordinators that will be able to review the information with you and update also our system, our Epic system. They can go over the benefits so you are aware of how your insurance works and what kind of benefits you have.
Let's add to that. They've got more experience with all of that, given all our experiences, than any one of us. Thank you. Great idea. They've got all sorts of resources. Skin cancers and cancers. I'm going to talk a little bit more about that in a minute, but I got to remember a number of years ago, one of our support group meetings, guy came in and his face was really all bandaged up and stuff. He really had some great work done. And everybody in the support group was screaming in positive praise about this guy Miller, Chris Miller. How many know Chris Miller? Really? Okay. More of you should know him. He's the dermatologist here that does nose surgery. I spent my first 10, 15 years fat, dumb, and happy. All right? Dermatologist within a mile of my house, lovely lady, loved going there. Every time, hey, simple, what's bothering you? Not much. You know, oh this, oh, spray that good, okay. Fat, dumb, and happy, okay? Chris Miller was doing a presentation, and one of the many pictures he had, which were horrific pictures, was somebody whose face was totally exposed in the surgery. And he said this gentleman was 17 years out from a heart transplant. I'm sitting in the audience 17 years out from a heart transplant looking at this. And he said he came too late. This is what we had to do to him. 3 months later, he was dead. What I didn't know was skin cancer, as she said, can be invasive. Once they get into the arteries and so forth, they can go any place. Get them early. A bump in the road compared to what you've been through, just if you catch it early. Same thing with that foot problem, right? If I had reacted quickly, which I do now, it's nothing. And so guys especially, don't be so bravado. Accept the invitation. They've never been anything but totally receptive to that call. They want to take care of it early so it becomes just a little story, as opposed to we lost another one. Back to what I was just saying here. A couple things to share with you. One, 20 years. Now you've seen this picture before if you've come to these before. 20 years ago, this October 19th, or October 17th. That was me, well it wasn't the 19th. It was 8 days after the 19th when I came home. God, he looked slim, didn't he? In 1998, at the U.S. Transplant Games, that's me swimming. It comes from the front page of the USA Today newspaper. I wasn't much of a swimmer, but I gave them a story about the success of transplant, ended up on the front page. Every one of you has a story to share that promotes organ donation because people understand that, wow, you're doing so well, you're alive today because of organ donation, they should be an organ donor. All the education they do cannot overcome what you can do as one individual sharing your story. So get out there with a smile, share that story. And I went back to work for another 11 years. I retired in 2005, and as I often say, I gave my gifted heart back to Pam, a donor mother in marriage. She lost her 13-year-old son to somebody on a cell phone driving down the road. He was on a bicycle and killed him. And so we partnered over the Gifted Life Donor Program volunteering, became good friends, and in 2005, like I said, I gave it back. And so sharing some secrets as I've just been doing. One, definitely compliance. You know, there's no reason not to do what they're telling us. You've trusted them with your life. Believe me, I can't tell you how caring they are. Pat, one time, I came in here with a box on my shoulder of books that I put out, you know, from Second Chance out there. and it was heavy, and my knees were not getting younger. And so I went to see Debbie about it, and she goes, tell me, I'll come out to your car and help you carry it in. Oh my God, let me carry this in. You know. And anyway, somebody saw me going to her office and I was out of breath. 2 days later, nurse called me at a restaurant with some friends, called the house first, oh no, Jim's out there, called the restaurant to find out if I was okay. That's the kind of team we have. I mean, I like to say they own us. You're family, and you're a very close family. And they're not going to do anything but watch you that closely. And so it's always been impressive. I came in here back years ago when I came down with diabetes, and the numbers were off the chart in the local hospital. You go to heart transplant, if you haven't had the experience, they don't want to touch you out there. They don't know what that's about. You're, ooh. And so at 2 o'clock in the morning, I was the ambulance down here. I hadn't called the heart team. 2 o'clock in the morning, the heart team was standing outside the room when they brought me up there with a scale outside the room so I wouldn't have to go whatever they do. And for the week I was here, they watched so closely that I got in trouble when I was being discharged. One, my wife said, I don't think you should get out of here yet. I said, hey, I'm not pushing. They said, I'm released. And so as we're doing the final education about diabetes stuff, this woman comes in, who I must admit I didn't know who she was, and she said to the nurse, what are you doing? Well, he's being discharged. I didn't discharge him. She was the nurse, the doctor in charge of me. I didn't know that because I had so much care from the heart team that when they discharged me, I was leaving. All I can say is this is a great team, and I work with all the hospitals, so I can really see a difference here. And another secret I share with you is get involved and get back. Whatever your passion for life is, that's what's going to give you longevity. If you don't have an interest, if you're bored, man, do something about that because you're going to die young. Get out there, get passionate. Whether it's your family, if you've got the energy and are active, we've got the Up Second Chance group. That's what these meetings are all about. Gift to Life Donor Program is the organ procurement organization in the area. They have a volunteer organization. They have a transplant house, much like I have a transplant house here at Up. And they look for volunteers. It's a great way to help others who are following your path. At the same time, just by your actions, inspiring them. They're looking at transplant, they're scared. And you come in, you do whatever you're doing, and if they find out you're a transplant recipient, really? I do book reading nights over there. Sometimes you get 2 people, sometimes you get 7 or 8. I do movie nights over there. We have a transplant movie and have discussions. Sometimes we don't even get to watch the movie because one person shows up, we get in conversation, and it's all about what they need, not the damn movie. And so there's all things you can do. TRIO, Transplant Recipients International Organization. I'll tell you a little bit more about that in a second. And then you've got United Network of Organ Sharing. That's the organization that's contracted to the government to take care of everything relative to transplant. Your organ was coordinated through that. The allocation rules come through that. They're supported by some 20 committees, and patients constitute about 1/3 of the representatives on their 42-member board. And if that's your thing, you can be involved in that. Take your experiences, be the voice of the patient on those committees. I can only tell you, it was probably 12 years ago, I got involved with the Thoracic Transplantation Committee, that's heart and lungs. Can you imagine if you had a heart transplant sitting on the committee making decisions about the allocation rules? I must admit, I was kind of in awe of the doctors around me until I finally figured out, wait a minute. They may do them, but they never had one. And they were very respectful. They listened to the voice of the patient. And so today I serve on the executive committee of their board. And it's been such an amazing experience to be part of paying back, if you will, through that kind of experience. So find your passion. What's your reason for living? And by all means, come on out to these things. Network with success. Come on out, meet people out there long term, realize this can be your future. Second Chance, for example, does have financial support. See your social worker. If you're up against it money-wise, there's a limited amount of money that's available that we raise every year. And this is Jim Bullard. He's out 6 years with his heart transplant. And myself presenting from Second Chance $1,000 gift to the Gift of Life transplant house on the other side of town. Trio Philadelphia, a couple of years ago, created a book for children. Now, this isn't a child getting a transplant. This is for somebody who's in a family where the family is getting involved with transplant, okay? And so your social workers have copies of this. We don't sell it. We give it away. We're in our third printing of a book that was actually created from a story of one of our patients here. We got the phrases down to simple phrases and had the kids you see in this picture, who are children of transplant families, draw the story. And we created this book, which, like I said, has gone through 3 printings. It's all over the country right now. We're putting it in libraries and stuff like that. So if you have a child, a grandchild that needs to understand transplant, it's an introduction to that. And along with that, all sorts of ideas of things you can do with them, online, other resources, etc., to help them understand what the transplant is all about. Other exciting thing right now, I got to tell you, back this spring, one of our board members out in the West Coast called and said, "Jim, we just lost so-and-so to cancer," one of the transplant recipients. And that's really sad. And he said, "What are we going to do about it?" What are we going to do about cancer? I'm sorry, I really sat back and said, yeah, right. After I got off the phone, I thought, you know what? An organization like TRIO should do something about cancer. I had no idea what. So I called him back and I said, you know what? We should do something. Let's see if we can figure out what we can do to help. And so he and I have been researching since then, talking to people like Chris Miller and others who deal with post-transplant cancers, and saying, what can we do as an international organization to help you support patients like ourselves, post-transplant, facing the high risk of cancers? And so just this past Monday, I finally got approval of the board to spend the first $10,000 on what looks like it's going to be a 5-year plan of finding things we can do that will help you and me and others deal with the high risk of cancers. What are the best practices? You know, how can you prevent them? Early detection, diagnosis, recovery, all that kind of stuff. And so this is the TRIO Cancer Education website that we're going to be building. And each of those boxes represents some text that will talk to you about the urgency. Secondly, a summary video from one of those transplant doctors talking about the cancers and what they treat. And then further, that 5-minute summary will be followed by a full hour-long. So for example, Chris Miller came to our support group. All right, we've got the facts, we make a summary out of that, and then if you want to sit through the whole presentation, you can, and you'll see what I saw that night. And that will be available for everybody. And so that's the kind of thing we're doing. Life is filled with opportunities. What are your opportunities? I share some of those that I found. The last one is my latest, Hospital University of Pennsylvania. What? TFAC, Family Advisory Council. P. Patient and Family Advisory Council. They have a council here of patients and caregivers who meet monthly and are resources to be drawn upon by the medical professionals throughout the system when they're looking to do something and they need the patient influence on that or view on it. Fascinating. And so it's been really special to be able to pay back in that way. The opportunity is made possible by a donor. In my case, Roberto Cuevas, 38 years old, celebrating his birthday the early part of October over in Brooklyn, New York. He was the wrong place at the wrong time. Got attacked on the street and beaten about the head with a baseball bat. Ended up in a coma. A coma is not death. 8 days later, he progressed to brain death. And so on October 18th, his brothers and his siblings got together and made a decision for him. He was brain dead. They decided, through Roberto's leadership, to say yes to organ donation, and that registered back in 1994. And so he became my donor, and I just finished my annual letter to them just the other day, sharing what life has been like. And I got to share with you, last year, I got a little concerned when I went to sit and write that letter. I said, what am I doing? Am I bringing up bad memories for him? And I got a phone call from him. And in that phone call, we had a conversation. He said, I'm so looking forward to seeing your letter again this year. And that weight was lifted off me, and I wrote the letter, which I do every year. Gives him some insight as what his brother's heart is still alive and doing. And so one of the things you can do, whether you meet the family or not, very small percentage ever do, don't expect that. But by all means, say thank you for the gift. And so there's many other opportunities you find on the website. There's the Second Chance Heart Transplant Support Group Incorporated, the acronym you see up top there, website. Have that Celebration of Life dinner dance in the spring. Over 800 local heart transplant recipients are members of that. You have the TRIO web website. We just did a candidate workshop down at Crozier Medical Center, for example, being a panel for the doctors talking about the new kidney allocation rules, for example. And that primary care, post-transplant cancer PTC focus is something we're very excited about. You have opportunities with the Gift of Life donor program, donors1.org. Our multi-organ support team meets over at the Gift of Life offices, and typically on the fourth Thursday we have a speaker. And then we have the transplant movie night, usually on a quarterly basis. I have to confess to you, we've used all the good movies. We actually have a database of every transplant story movie we could find. And about 15 of them are any good, and the other 100 are just horror flicks. And so we're going back and recycling over them, because there's no new ones out there. And so I leave you with our daily challenge. Okay? We don't defeat death with a transplant. Rather, you get an extension of life. So the real question becomes, what are you going to do with the days, months, and hopefully years of extended life? The same question, even the non-transplanted phase of their own lives. Think about that. And my daily inspiration, I want to live until I die. And that means today, living to the fullest. And so I'd like to close with a very special thank you. Pat, Maria, could you go for a second? You've seen these books in the waiting area. Second Chance always takes a moment to say special thank you, and I've got one here. The Secret to Living is Giving, from Pat, from your many years. And The Road to Happiness, Simple Secrets to a Happy Life, Maria.
Well, thank you.
Thank you. And of course, a special thank you to our social workers who really are the marketing department in one sense. I mean, if you had an email address, you got a flyer. They got on the phone, and every day I give them an updated list of who's responded, and they follow up on the rest of you. And so if you got a call from them, that's why. They did a great job. And Deb, where are you? I can't see anything up there. There's Debbie up there. Sally, she's not going to be here today, right? And Claudia, there you go. Help me out. Don't forget, if they didn't ask you when you came in, and you don't have your email address on that list, it's so much easier for us to contact you. And last year, it's especially important because the storm came in, and all of a sudden we had close to 80 people we had to contact and say, whoa! Okay, so if we have that contact information, that's what it's used for. By all means, enjoy the lunch. Pick up your parking voucher. Who's got parking vouchers?
I have them.
Okay. Watch for her. And by all means, when you sit down at lunch, don't sit at the table of the person you know. Find some new friend. Every one of you out there has got an amazing story to share. And don't forget, Monday, December 8th, you'll get another flyer for the Transplant Holiday Party. And on Tuesday, February 5th, our next meeting like this, where we'll hear Kathy King talk about nutrition after transplant. And so, thank you for coming out, and I hope to see you again at the holiday party and for many more years like this. Thank you. I do have a couple of copies of the children's book. If anybody wants one, please feel free to take it, okay? I'm just trying to get them out there to the children that can benefit from.